Welcome to this episode of The Compliance Guy. It is Monday, January 30th. It is my mother's 82nd birthday. Anyways, it's my mother's birthday. So prior to going live, we were having quite the interesting discussion about fast food chains, whether it was Chick-fil-A, Whataburger, In-N-Out, Jersey Mike subs. So y'all feel free to chime in and let us know what your restaurant is, and we could talk all about whether or not we like it. All right. So as always, thank you all so much for tuning in, logging on, and just hanging out with me and my distinguished cast of characters. As always, Paul Spencer, Christine Hall, Scott Kraft, Terry Fletcher, and Stephanie Allard, who will once again probably talk about coders insurance. So we'll see how that conversation goes. It is a Monday. On a Monday, it has been a fascinating day. I got an opportunity to do a live webinar for the National Alliance of Medical Auditing Specialists. We had about 490 folks that joined in live, so nice audience size. Hopefully everybody enjoyed the presentation. If they didn't, I told them my name was Shannon DeConda. I was just under the weather, so I had a deeper voice today than what I normally have. Terry Fletcher wasn't available to blame. So anyways, with that said,
I think, Sean, you're frozen.
But while you're frozen, we do have a commenter, Sheila, who said it was a great webinar. So you have that going for you.
Yeah. She said, yes, that was funny. Yeah, Sean, you are frozen. So did you Chrome as you tell us to?
That's a great one, Terry.
I know, right? Well, maybe we should start us off while we figure out if Sean can get back on here. I know that we were talking about contracting and credentialing, which are two completely different things. Whose topic was that wanted to throw that in there? Was that Stephanie's thought or
Paul? I can start.
All right, Steph. Well, hopefully Sean will get on.
Yes. So one of the things that I've found, and I know we've all been talking about our personal scenarios where we come across this as well, is that when our practices are bringing on new providers, they don't really think about the onboarding process as including credentialing or even getting ready before you hit the onboarding process. So I was talking with a group last week, and it was one of those things where, you know, they just start talking like they're adding a new physician and they're automatically going to bill incident 2 because that's what their friends do. Everybody gets paid. Why would we not do that? Why would somebody work for free? So, you know, hopefully we're all laughing equally here because this is a huge issue. But one of the conversations I've started to realize that we need to have up front, even if it's for future, for fixing the onboarding process, is credentialing. Making sure that they're aware that everything has to be filled out before. One of the things that I find as well is that a lot of the clients do not realize that CMS will backdate typically to the date on the application, but not all of the commercial payers do. So if you do this correctly, you can have people working multiple weeks in a row and none of that work's going to be reimbursed. Before I throw this over, and I know, Christine, you have a lot on this as well, the other thing that everybody forgets, they only remember the part that a physician will bill out all of the services for somebody else. What they forget is that these providers cannot be making their own treatment plans. And I don't know about you all, but for myself, I really do not see a physician coming into a practice and working under another physician not making their own decisions. Christine, why don't you go ahead?
Absolutely. I think there's this huge misconception. I actually emailed Stephanie this morning. I was like, get out of my head. Too much of this is happening right now. There's something in the air, the water, whatever. I got 2 calls last week regarding the onboarding process and how we're going to bill out the new provider that's coming on board and whether it's fee for time compensation or incident 2. And I'm thinking, wait a minute. We have some pretty spelled out guidelines when to use either one of those types of Medicare benefits. And I say that because those terms belong to Medicare benefits. Now, do other payers have the same type of structure program? Possibly, but you need to be more aware of what that is with each individual payer. Not all payers are created equal. And like Stephanie was saying, have a policy that when you sit down and you do those negotiations, you're doing your due diligence, you're looking to have a new provider join you, that contracting, you want to make sure that that's the first thing we do. Let's pick a date to start, sign the contract, and send it over to credentialing immediately so that they can get that ball rolling, but also have a policy in place or a plan in place of what are they going to do until then. If you and if you lightly want to touch on incident 2, and I know, Sean, you've shared with us that there are extraordinary exceptions when you think that a physician may be able to, and again, I'm using all of these words because there's no definitive, there's nothing in writing that we can find that says physicians can do incident 2 physicians, but I think I've heard you talk about the gray zone.
There actually is something that
There
we
actually
didn't
is.
have. Yeah, it's CFR 410.26, and I
That's
hate
right.
that, by the way. I absolutely hate it because Sean brought it to my attention. But it does say, and I really appreciate, Sean, you saying that.
Yeah.
Rare circumstances. It doesn't
That's
mean it's a free for all to go ahead and do that. But just real quick, Sean, before you go there, and just back to Stephanie's point. Does anybody on the panel ever get this happen where they bring in a new physician? I mean, credentialing and contracting, okay, but they forget to ask their staff if they know anything about the specialty. I have a really big client right now that's a healthcare multi-specialty group, over 100 physicians, and they emailed me recently and said, "Hey, Terry, we're bringing in a radiologist, oncologist, 2 pulmonologists, and also a OB-GYN oncologist," which I haven't heard of that subspecialty before. And they said, "Do you know anything about it? Because we don't. None of our coders know." So, Paul, what have you heard about that? Has that happened to you?
Well, not so much that, but one thing I'd like to address, and I'm hoping this is for the final time because I get this question a lot. No, Locum Tenens is not used for when you are credentialing your physicians. Now, my Latin is rusty, but vaguely, Locum Tenens means in place of, which means there has to be a doctor who has left and is planning to come back. That a Locum Tenens is a placeholder. So if you are trying to use Locum Tenens for somebody who is new to the practice, they're not replacing anybody and they're performing services, you cannot do that because somebody has got to be missing and somebody has to be coming back. It's not used for that. So don't ask again, all of you.
Well,
Hey,
here's
Sean,
the other
did you
thing
see
too.
what Pam just said? Did you see what Pam has said in the?
I will
in
in
the
just a
chat?
second, but
That's weird.
yeah. So yes, the section that Terry had read from does allow for incident 2 services by a physician with another physician. But the other point that I wanted to make was this. Locum tenens is not for use when you have a physician go away for a period of time and you want to replace them with a non-physician practitioner. It is a physician replacing a physician. It is not a nurse practitioner or a PA replacing a physician. There is also a great Q&A from the Centers for Medicare and Medicaid Services. And this issue actually was addressed in 2015, August 10th, as a matter of fact. And what CMS does say, and Terry nailed it on the head, it's the Code of Federal Regulations 410.26, and it's also in Chapter 15, Section 60 of the Medicare Benefit Policy Manual. So keep in mind, with Medicare, you have 2 different manuals. You have the Medicare Benefit Manual, Medicare Benefit Policy Manual, and then you have the Medicare Program Integrity Manual. The difference between those is that the program integrity manual gives guidance to the contractors, right? To the certs, the racks, the mix, the max, and it tells them based on different scenarios, different ways of auditing, different ways of doing statistical analysis, all of those different things. In the Medicare benefit policy manual, that is specifically to providers of healthcare services to make you aware as to how to document, how to bill different services. So let me look at what it is, Terry, that Pam, is this what you're talking about? So you mean we have
Yeah.
to credential our
I'm hoping she was
Yeah.
joking.
Yes.
No, we've had clients that we go in and find out that none of the NPs or PAs are even credentialed. And then they wonder why we're saying incident 2 isn't okay, which, I mean, in the past, there have been a couple of payers who didn't credential the mid-level providers. But if they do credential, it's not like it's optional to go ahead and enroll them. They've just completely disregarded everything and billed it all under the physician.
I have a great question on this. I don't understand something that maybe you guys can, give some insight to our listeners and also school me on this because I don't understand this. So let's say that you, on this rare occasion, bill for a physician who wasn't credentialed incident 2. Okay, so let's just say you did it. Well, that means that patient, what if that was a new patient? There's no incident 2 rule there, so you can't see that new patient under the incident 2 guidelines. Let's say it was right. Well, let's say it was an established patient and that doctor's trying to build a practice. And so he saw one of the other physician's patients that had a care plan. Well, you're still going to get 85%, correct? You're not going to get the 100%. Well, I'm getting questions about if that happens, then when does that doctor kick in for that 100%? Let's say if they take over the care, I would think only if there's a change in the patient complaint or management. It wouldn't be for that care plan that's being carried out. But I'm finding a lot of non-compliance with new patients that they're trying to bill under the incident 2 rule. And I'll throw it back to you guys. That doesn't qualify as incident 2, correct?
That goes back to what I had said a few weeks ago, that a lot of providers don't understand the difference between the collaboration agreement for the licensure or that arrangement and the policies of the payers. And there are no two payers that are alike. There's some might be similar, but Medicare doesn't apply to Cigna. Cigna doesn't apply to Humana. We really have to look at those individual payers.
And I think what I would add to that, and Sean, you and I have seen this before, the fact that the payer may not functionally follow its own policy, either because, you did not properly apply, or you sent them something about a provider who was not credentialed and they paid you anyway, does not preclude them from taking that money back later on. So it really is, as we say in many situations, ignorance is no excuse, right? And you have to be aware of what every payer's individual policies are, because we get those questions all the time. I mean, the next level question I get after the incident 2 question for new patients is, well, how about I just come in and write the plan of care after the quote incident 2 provider has done all of the rest of the work, essentially turning it into like a split visit in the office setting, which is not permitted. And as I constantly remind people when I talk to them, the thing they also have to remember, and I think Terry mentioned this, these are Medicare phrases, right? These are Medicare specific policies, which, because Medicare may do it one way, doesn't mean that every payer may do it. And I think one of the things that Stephanie had talked about, I think Christine talked about it, is you should have a hiring plan in place. So we have seen one of the comments that came through from Missy. She had mentioned that, and sometimes the way that they find out that there's a new physician is when the charges start coming through, because nobody knows that this person has been hired. And so there has to be like a hiring plan. Like I'm not a physician, but whenever I've been hired, there's a lower paperwork burden, of course, but I have to fill out things for taxes. I have to show that I'm eligible to work, in the United States. And all of these steps have to be mapped out for physician hires as well, in terms of, can things be, who can this physician see? Can there be claims that are held pending the enrollment approval of an enrollment? Or if you're seeing a patient who has a plan that does not permit that, is that just going to be written off right out of the gate? Like, you have to figure out essentially how to onboard a provider in a way that keeps them working to the extent possible, as well as, seeing people for whom they can see for payment purposes, and not seeing people who they can't.
Well, now, Stephanie, credentialing and contracting is different, right? There's
Well, yeah,
contracting
the
with the payer and
contracting with the
credentialing. Yeah.
payer. Yeah, credentialing is enrolling the individual provider. And one of the things too, along the lines of what Scott was just saying, when we think about the workflow, essentially you want to think about the way you're going to schedule a provider. So if you're paying attention to when you receive confirmation of an effective date, maybe start filling their schedule with Medicare patients if you're enrolled with CMS first. Look at the payers from there. And then also think about the fact that we know that typically CMS will backdate to that date on the application. So maybe allow them to see Medicare patients and hold the claims, track the claims, don't send them out the door, wait till you get confirmation and then bill from there. So there's different ways to look at this, but just having, a free-for-all scheduling with everybody, it's not going to work.
And I think also, and I hear this all the time. Like, if a provider is offered a position, I mean, today's January 30th, right? Like, if the job offer goes out and gets accepted today, like, what's the start date? Is the start date like February 14th, 21st, whatever that is? Getting that process rolling, like, you have, like, every day counts, right? Like, every day matters in terms of understanding, which, if you're a larger group that's doing this work more frequently, understanding, which payers are likely to take longer than others, what your contracts require you to do with each of your payers, so that you can prioritize the right things.
And I just wanted to comment just one more thing on the locums. Remember, for those of you that ever do that, locums tenens, which they've actually changed the name of that now, substitute physician, not replacement physician. If you keep that in mind, then you'll be fine. Substitute, not replacement. It means at some point there's an anticipation that physician's coming back. As soon as they leave the practice to go elsewhere, to practice somewhere else, or they're, a leave of absence is great. But if they're saying I'm out of here, that's not locums. So just keep that in mind.
Yeah. And real quick, I want to go back and just address one thing. Keep in mind that the retroactive for Medicare is 30 days prior to the effective date of enrollment. So, please keep that in mind as well. All right. So I think we did a thorough job of talking about the incident 2 and locum tenens. And I apologize. Apparently, if you turn the microwave on in our house at the same time I'm on the computer, it will actually trip the entire fuse. So my 11-year-old granddaughter was making popcorn and everything went, and I went, oh crap, somebody's using the microwave. So welcome to a 1946 built house. Okay. So with that said, I want to jump into another topic. Because Paul, this is one that today you and I actually had to deal with, right? And Terry, it was actually interesting because you and I got to have a sidebar conversation about this today. And it's the word inference, right? So one of the things that I think is extremely important for our coders, our auditors, documentation reviewers, whatever label you want to put on your job description. In the absence of definitive language in the progress note saying I am ordering an A1C or I am ordering an MRI, as long as there is relevant information for that date of service, it can be inferred that those services were to be ordered. And as such, the billing of those services and the reimbursability of those is that a right word, reimbursability? Maybe.
Works for
I don't know.
today.
It works for today.
It is now.
Again, it is now. It's a Seanism. There is justification for that. So, Paul, let me pause because we actually wrote a report today for a law firm where we talked about inference. So, do you want to talk about that? And then I want to go around the panel if we can.
Well, certainly. So this particular provider, not very good documenter. What they're, I looked at thousands of pages of documentation, and the assessment plan for each patient was a list of conditions, and below it a list of treatment options or a list of recommendations. The problem is that they're not tied together in any meaningful way. So the provider of service here is not meeting the auditor halfway by saying, this is the test for this condition, or this is, the type of care that I am recommending for this particular condition. So whenever you leave it up to an auditing entity, particularly a government auditing entity, to guess, they get very short-tempered about things like that. So even though the order for the services based on the conditions and based on the very brief notations that this provider put forward said, we can infer that those orders were made. Ideally, because so many people have their eyes on that documentation potentially, you want to make sure that you're tying the orders for all diagnostic tests and diagnostic services to the conditions that you're treating. Yes, you can infer it from a legal argument standpoint, but you don't want to leave it to hope. Nobody should just live on hope.
Hope is not a plan. Remember that
yeah.
saying?
Well, wait a minute. Hold on. Isn't what hope? Isn't the resistance what it was built on? Was built on hope. Sorry, just a Star Wars. Sorry about that, Terry. Let me come to you real quick because as an auditor for insurance companies, I want to get your take on inference in the medical record. If something isn't clearly documented, but you can infer the reason for doing a test, how do you, and I know you have your RN degree, but you as an auditor, how do you look at that from a payer's auditing perspective?
Well, I think the problem that we're having is I'm actually going to disagree with the inference, but that's what I'm here for. Cause trouble. The reason I'm going to disagree with it only because from an auditing perspective, okay, the AHA, American Hospital Association, that basically tells us how to use ICD-10 codes, they are clear that if you cannot tell from the record what's going on, you have to query the physician. You can't, and I'm going to air quote, assumptive code. So the only thing that they've let us assumptive code is COVID. So at the beginning of the pandemic, they said, well, even if you have a negative test, if the doctor thinks they have COVID, go ahead and report COVID. And we're like, whoa, who said that? And we're like, oh, CDC and AHA said that. And we're like, wait, what? Well, then they came out in September 2020 and said to hospitals, oh, but wait, if you don't have a positive test, then you don't get your 20%. So you can put it in as COVID, but you're not getting money for it. So they basically went, oh, well, then why would we do that then, right? It's about money. But as far as inference, the problem I have with it is it turns clinical documentation integrity specialists or the integrity of the documentation, it turns it to people who are not the physician, who may not have a clinical background, into basically getting in the physician's head or the provider's head and making that inference on what the thought process was. And I don't think that's appropriate. I actually think that, and it also, to me, it almost gives the physician an out when it comes to being lazy about documentation. it's kind of like, you know, telling your kids, well, you get $5 if you clean up your room. And they're like, well, I cleaned most of it. You should just realize that I meant to clean the rest of it. And so I wouldn't give them the money. It's like, no, all or nothing. Same thing with this, and in kind of given a comparable, is that I believe that the only way we're going to get providers, and I'm using that physicians, mid-levels, whoever's touching the patient and having to document, and that's consideration for reimbursement, you're going to have to be proactive in what you're doing and make sure that there doesn't have to be an inference on what you did, that it's clearly documented in the medical record. I just think that we can make mistakes from an inference perspective, saying, well, I can assume here that this patient, because they're diabetic, they're automatically going to be slower to heal. They're not going to recover as well as somebody who's not has non-diabetes. But what if the physician wasn't clear on what stage of diabetes, what part of diabetes? And to me, now you're getting into a legal situation. So that's just my take. I think Christine might even probably have an addition to that.
You know, recently I've seen it from both sides of the coin. I was asked a question because the auditors had requested that from a group of physicians. We need you to match the lab with the diagnosis. And to the point where it was one diagnosis of diabetes and one lab of A1C, and they wanted the auditors were denying this because they wanted to see that A1C is ordered for diabetes to check the glucose levels. And I kind of felt on both sides of that yes, we want to see that, but on the other side, it was one diagnosis and one test that is the usual and customary test for that condition. So can we infer that one test and one diagnosis? Of course, when we get into more diagnosis and more tests, that's where it starts to get a little muddy. Or even, and I never give credit for those ordered labs because I don't know what labs you ordered. Did you order dengue fever labs? I don't know. But that's kind of how I look at it. I'm kind of stuck on both sides of it. I don't want to say that we shouldn't infer under certain circumstances. I think it's going to be specific. If it's one diagnosis and one test, and those are the usuals, I may not have anything to say about that today.
I just think it gives physicians and providers a reason to get around the system, and I don't like it. Tell us what you're doing. I agree with you with the one test and one diagnosis. To me, that's almost, well, they're not doing anything else. But when you deal with multi-system issues and one test could be for different things, then I think you've got to be careful with that.
I agree. And I think when I think about inference, when it comes up in conversations that I have, the one thing I say to the providers is, I will never go nearly as far with this as you want me to. And I will not go nearly as far as like you're going. So I was working with a provider recently who, I will preface this by saying, I don't think this provider was particularly nimble in the electronic medical record. And so the only thing that this provider was inserting in his note, there were smart phrases that would say things like, some of the labs are abnormal, and I discussed that abnormality. And I'm sitting there and I'm thinking, boy, I wish I knew what it was. I have no idea what's abnormal other than something. And within the list of diagnoses, the provider would list the ordered lab next to the diagnosis. Sometimes it would be the same lab. And this had gotten to a point in a conversation where it was being suggested to me that I should infer, because of the presence of a medication list, that those medications were being managed, even when the provider was not going as far as saying things like continue present management. And so really stepping away from that idea of inferring things. And one of the things that, for me in particular, when you think about these new guidelines that we've used for a couple of years, the provider has pretty wide latitude to get credit for things discussed and for things done, but it's moved away from this notion of just because these diagnoses exist, they confer to the table of risk. And even when it comes to inference, like the one phrase I've been stuck on the last couple of weeks, and maybe it's just the type of notes I've been doing the last few weeks, is this phrase like supportive care. I'm like, I don't really have a great handle on what that means. But sometimes that is literally like the only phrase that I see in the assessment and plan. And usually I'm just taking that down to like a level 2 because I'm like, well, I don't know what the risk is. I don't know what that is. And so I think, it's an extremely slippery slope. And I'm on board with this notion that if we're talking about a patient who has diabetes and only diabetes and an A1C is the order, or if a patient who has, some sort of worked up, hip injury and we see like a hip x-ray. But like I said before, I'm not going nearly as far as the provider feels like I should go. And I'd rather not go there at all when there's a fairly elegant solution, which is just document clearly what you're doing.
Well, and we get into trouble because, Scott, if we don't go there and do this inference, right, they're like, well, obviously you don't have a clinical background. And then if we do go there, they're like, well, then you should do that for the rest of my records. We can't win sometimes in these situations.
Right. And, the other thing I see all the time now is I'll see a list of diagnoses, and then I'll see some treatment plans, and then I'll see like others. And then I'll see a bunch of other stuff in there that I'm supposed to try to match up to these different things. And it's not even listed under a diagnosis code. It just says like others. And I'm an old TV person, and I think only Paul will maybe recognize this. But when Gilligan's Island first came out, they never mentioned the professor and Marianne in the intro. They just said, and the rest.
And the rest.
And that's what I always feel like. I'm like, well, I don't know
That's awesome.
So let me jump into this fun conversation for just a minute. And for those of you that don't know what my middle name is, it's actually Loophole. So let's talk about the loopholes that the Centers for Medicare and Medicaid Services give us. Now, I want to preface this by saying, let's be preemptive, right? So I agree wholeheartedly with Terry, with Scott. Let's make sure our providers are documenting the necessary in advance, right? Let's make sure that they're giving us complete, accurate information within the progress notes so that we don't have to infer. But here's what I want to share with you, and there's two things. Per the CMS guidelines, MLN 906764, which is Evaluation and Management Services Guide 2022-06, if date and legibility identity of the observer if the rationale for ordering diagnostic and other ancillary services is not documented, it should be easily inferred. So this was CMS. Let me rephrase this. Simply put, quote unquote, if the rationale for ordering diagnostic and other ancillary services is not documented, it should be easily inferred. Now, this is straight from the Centers for Medicare and Medicaid Services. This is not from a local coverage determination. Now, the second thing that I want to point out, and remember I was talking about the difference between the Medicare Benefit Policy Manual and then the Medicare Program Integrity Manual. So if you go to Chapter 6 of the Medicare Program Integrity Manual, and you look at specifically, let's see here. This is Chapter 6, and this is revision 10365 10-2 of 20. And you go into this document and you put in the term infer. And it's going to give you a couple of hits. And what it talks about in here, this is for the inpatient hospital setting and for SNFs. It talks about rules of thumb. And here's what it says. Medicare contractors must not make denial decisions solely on the reviewer's general inferences about beneficiaries with similar diagnosis or on general data related utilization. Any quote unquote rules of thumb that would declare a claim not covered solely on the basis of elements, including but not limited to, and they give a bunch of different things, is unacceptable without individual review of all pertinent facts to determine if coverage may be justified. So what they're basically saying is that you cannot look at an individual date of service, specifically here in the inpatient setting, in a vacuum, and make a determination that the services are not reasonable and necessary because you weren't able to infer something from the medical record. So listen, I agree 100% with this panel discussion on this topic, but also understand that clinicians are not perfect. They're human. They use scribes sometimes, they use medical assistants. And if something doesn't make it into the medical record in a definitive way, as long as it can be inferred, according to the Centers for Medicare and Medicaid Services, it is reasonable.
And the only thing
Go ahead.
I would say to that is really, it sort of goes back to that statement I said at the outset, right? Like, to the extent I'm inferring things, I don't have the basis to go probably as far as the provider wants me to go. And if we're talking about, this is a best practices audit where we want to avoid having that argument with the payer, or the payers making a recoupment request. I talk about this sometimes in the context of the independent historian for like kids, right? Where I very rarely see it documented as clearly as, this is an independent historian due to the developmental issues of the child. But I see like independent historian or informant mother, and the kid is 16. And I'm saying to myself, okay, so this kid can't explain like his or her health condition. Like, what is the basis point of it? And that may or may not be a fair inference, but if the kid's 2, I'm probably going to feel a little bit like differently about that. And so I think
Absolutely.
in a way, like, I appreciate that point. It doesn't change like what's our best in class solution, right? Our best in class solution is say, this kid's non-communicative, so I need an independent historian. Like, make a macro, put it in the note, take the decision out of my hands, right? Don't put me in the place where I'm coming in with like a referee's uniform and I'm saying like, do I think this is appropriate for this or not? Like, do I think, can I infer, I've seen a million commercials and stories about it now, but can I infer that Ozempic is like a weight loss drug right now? Is that a weight loss drug now, right? Like, it seems to be becoming one, but those are that's my feedback on it, right? Like, I think there's a window to do it, but the window probably won't be as wide as people would prefer it to be.
Well, here's one that I
Scott,
deal with. I
And
deal with one on oncology. I've got an oncologist that has patients under chemotherapy, and some that have finished their trial of chemotherapy. And the documentation for the ones who have finished says patient doing well. They're now in outpatient status. They don't need to come back except for maybe they call it an AWW, mean audio and AVV, audio and video visit. Later on, and they even put level 3, which is funny to me. How do you know it's level 3 before you get there? But anyway, they're saying they could come back in just for a checkup. But then the patients who are under the chemo, they're still having it. There was and they have the same language in both. They say, and we're always monitoring for toxicity for this problem. Well, if the patient's done with chemo, why is that still in there? If they're done with what are you monitoring for? Patient did well, they're outpatient. If they're under chemo, plus they have other chronic conditions, I can understand that because they're monitoring, and this patient's been on it for quite a while. So do I is there an inference there because I audit for this one group that all their level 5s come through me before they even go out. And yes, that is something that I will infer, that if they're under chemo, they've got the chronic conditions, that there's a possibility of toxicity, then I will approve that level 5. But if they're already done with it, I won't, and I'll put them down to a moderate. So same type of patient, different area in their progression as far as what they're doing with their treatment, but the doctor says the same thing for each patient. So that's one that's really tough. And I've talked to the physician over and over about that, but he won't change.
no, that's a great point. That's a great point. All right, let's go, Christine.
So
What
I
do you
got a
have?
couple of things. I want to piggyback off Scott. When I start looking at documentation where you have that 16-year-old with mom, for an independent historian, I want to see what information did mom present that was different than what we got in the history that we needed to make this diagnosis, this plan of care. Without that, I agree with you. The other thing is that we really need to remind providers that when we're auditing, we're preparing them for what the payer is expecting. And at the payer side, they don't have neurosurgeons. There are no high-level physicians that are processing claims. These are administrative people. These are coders, billers, people that are not in that same clinical mind, that they can review the medical record and understand what they mean all the time. And for that, they put policies in place and expectations in place of what it needs to look like for the payer to pay the bill. And so those are the couple of things I just wanted to remind, the areas that I want to remind folks about.
And real quick, we have a comment here I think is great. There's a question asking what's the difference between client or compliant and legal. And I would say think of it this way. Think of best practices versus defensibility, and put a ton of dollar signs over the defense side, because that doesn't come at a cheap cost and you usually need somebody else.
Yeah, sorry, I was gonna say, like, when you think about if you're taking a note into like an ALJ hearing, and I've looked at the notes and I'm saying to myself, these notes are not particularly good, but I need to like polish them as best as I can. And the entity that's at that stage of appeal has already spent an inordinate sum of money trying to get this money back, trying to recover the value of these claims. That's, to me, is the difference, right? Like what we're talking about here, what I think about when I'm talking about inference is like, I would prefer you not be in that conversation. And I think if you're hiring me to do a proactive audit and you're getting dragged in front of the ALJ over stuff that we've looked at, either there's some unreasonable payer out there, or we're not doing as good of a job educating you and getting you to follow that education as we would like.
And we talked about this a few weeks ago. The cost of legal advice is not cheap. I mean, we had an example where a provider had an overpayment of $32,000, and the attorney walked into a Zoom meeting and said, well, to defend you, it'll cost anywhere from $50,000 to $75,000. So, which is absolutely ridiculous. Yeah, you win, but, boy, that's winning at a cost.
Yeah, and we addressed that, and we actually engaged directly with the Attorney General to take the cost out of it. So where this law firm wanted 50 to 75,000, we engaged, and I think it cost the client maybe 5,000 to get this whole thing, hopefully resolved. But I think this is a great question because I've been asked this before, right? What's the difference between compliant versus legal? And in healthcare, I think it's easily put that compliance is the safety team and legal is the insurance team. The bottom line comes down to that compliance is the process of making sure your business complies with any legal and regulatory requirements. Legal is the defensibility of the things that have been done. So and this is just my position on it, compliance and legal, while they can be synonymous in certain arenas, they're really not synonymous because they have different responsibilities within a healthcare organization. All right, I think it's a great question, and I'm so grateful for everybody who participates with us. Let's go to, we have a couple of other topics that we want to get to. One of them I want to talk about. Terry, since you've been so controversial today, I want you to close out the show. So I'll come back to you next. But I want to go to Paul Spencer. So after you finish chugging whatever's in your cup, let's talk about RADV audits, because there's a lot going on in this world right now. And let's talk about some of the concerning aspects of that and what you're seeing. And then Terry, we're going to come to you for our last major topic. So hang tight.
Okay. I'll try to make this as short as possible. During our broadcast today, an email hit my inbox. It basically said that CMS has finalized a rule which opens the door to a lot of clawbacks from Medicare Advantage plans, i.e. commercial insurance companies, based on their submitted information for risk adjustment validation. Now, just to quickly explain risk adjustment, this is the 35-second pitch. Risk adjustment is basically the idea that we pay a Medicare Advantage plan more money if they can prove in some way that they are treating a population that is somehow sicker than the next insurance company down the block. And the way they do that is through ICD-10 specificity. The ICD-10 clinical modifications in other countries are about 14 to 16,000 codes. Ours is 78,000. And they're, without an actuarial reason for those codes to be there, it would probably be 14,000. Enter risk adjustment validation. What it looks like is that the insurance companies being threatened with hundreds of millions of dollars being clawed back based on inaccurate information, which the definition of a unicorn in our society is something that is extremely rare and can't be found. My definition of a unicorn in our line of work is finding a risk adjustment validation audit by CMS that results in finding that an insurance company has submitted correct information in order to justify the additional payments that they've been getting from CMS. I've never seen one. And it's been over a decade. I keep looking, but I've never found one. So CMS is finally deciding, hey, we flushed a lot of hundreds of millions, possibly billions of dollars down the drain to Medicare Advantage plans who say they're treating patients who are sicker than somebody else's plan. It's time to bring people to the table.
Great insight. Any additional thoughts on the world of RADV?
I have a comment just along the lines of what Paul was talking about with risk adjustment, because I tend to do a lot of work right now with clients from the provider side. And actually, one of the clients is a large ACO organization. So they've taken it upon themselves to have us go into the smaller practices and do some chart audits. And, you know, when you think about that setup and the way that ACOs are comprised of all the different smaller private practices, sometimes 1 to 10 providers, a lot of times these practices I'm finding are not really ones who've gone outside for any kind of feedback, any kind of coding education. And I come in there and say, well, you know, hey, you did an annual wellness visit today, but I can't see how any of these chronic conditions were addressed during the encounter. And they're shocked. They're like, we've been told over and over again to put our chronic conditions in there, you know, to set our assessment up this way in an EMR system. And it goes so much deeper than that. The end result in all of, I shouldn't say all of the risk, a lot of the risk is on the shoulders of the Medicare Advantage plans. But when you think about it, it all comes and starts within the documentation of our providers. And because they don't feel it financially first, they don't understand the way that that can impact them. And I don't think, and I don't know if anybody on the panel has seen it here yet, you know, it's one of those things I always hear the stories, the scary stories about how it can trickle down and affect a provider. But ultimately, have we really seen it hit them in the pocket hard enough where the providers are really paying attention? And I don't think they are.
Will. I think we will, though, Stephanie. I think that, I mean, the logical response to that is if those clawbacks happen from CMS to the Medicare Advantage plans, are the Medicare Advantage plans going to reevaluate their capitation payments? Are we going to reevaluate the bonus structure now because that money doesn't exist anymore? They took that back from, Medicare took that back from them. So maybe you haven't seen it today, but as we've seen in the past, if we look historically, we will see it moving forward. And a lot of those organizations that have flipped over to a value-based model, they're going to feel it the hardest.
That's kind of what I've been envisioning too, is almost like a scorecard.
Yeah.
And how that provider shows up on that scorecard when they request all of those records. There you go.
Yep. Great point.
Yep.
All right.
Very quickly, moving on to the last topic. One thing that we've seen in the lead up to this final rule is a profound increase in the number of medical records that have been requested from practices to validate their risk adjustments. So if you think it's bad now, give it time.
Yep. And I agree. The MA plans are going to take it straight from the doctors. I agree 100%. All right, my friend. I am saving
the best for last.
I saved you for last. So And tomorrow, just so everybody knows, Terry and I will be back with another controversial topic on addendums, late entries, and corrections. So hang tight for that one. But Terry, I'm with you 100% on this one, and I would say 99.9% of the time you and I are on the same page. It's very rare for us to not be. I mean, we have some fun with it, but this one I am with you 100%. I'm just going to let you take this one because I don't want to take, because if I say it, I'm going to steal all of the thunder. So just take this one.
So one thing that I've noticed lately, and this has been in a couple of audits I've been doing, and actually this was one of my first audits I ever did for a Medicare payer several years back, but all of a sudden it's coming to the new forefront. I don't know why, but I have physicians and providers that I'm auditing that don't seem to know the difference between an RN and a nurse practitioner, or a medical assistant and a nurse. And this is a problem. So I have a particular audit that I'm doing, and without giving too many details, we've got 20 physicians, we have, I think, 10 nurse practitioners, 10 PAs, and guess what? We have one RN, and because the RN's been there over 20 years, they have allowed her to report E&M services over a level 1. They've allowed her to report things incident to, just like the other mid-level providers, which is incorrect, by the way. This is not correct. And so you have to stay in your lane. And the problem is that a lot of the providers refer to the term nurse as generic instead of, I mean, I was at the doctor recently with my husband, and he said, okay, my nurse is going to come in. It was the medical assistant. It wasn't the nurse. And so that was that's another situation altogether. But here's the problem in this one practice that I'm auditing. It goes back 10 years. Oh my gosh. And there was a total of $3.8 million that was billed out for services that could not be billed out under Incident 2 rules. All high-level services, even new patient visit. How's that? That shouldn't even be Incident 2 at all. But billed out, basically saying that this is the provider. And so this was just a mess. But guess who is the whistleblower? Anybody want to raise their hand? Yes, Sean, you know, it was one of the nurse practitioners. So two of them, actually.
They're probably mad.
Yeah, they were so mad.
Absolutely.
And just so we don't use profanity, it started with the P word, but they were not happy. And they basically were they kept coming in. Actually, it was kind of funny because we started it on site and then now it's being finished off site. But they would come into the area where I was auditing, and they basically were like, did you see this person? I'm like, I did. I've got it covered. They're like, okay, don't say anything. That was me. And then they'd leave. And then the next one would come in and go, hey, I just want to make sure. Did you get her stuff? I'm like, I did. I'm good. And then they'd leave. And it was just like, oh my gosh. And finally, I'm like, you know what? I'm going to do this, finish this remotely. They wanted to make sure that all of their, master degree, bachelor's degree, plus their, a lot of them have to do a residency in the specialty they want for a couple of years. They wanted to make sure that wasn't being overshadowed by, and I'm not, I still have my RN, but I don't practice anymore. Let's make that clear. But I keep it up because that took a lot of work. But basically what I'm saying is that I would never try to say that, you play one on TV. I mean, it's almost like somebody saying, well, they stayed at a Holiday Inn Express, so, they should be able to do that. But here's where we have to be very careful. And this is to the listeners, and we'll wrap it up with this. You have to be careful with your clinical staff. Who is ancillary? Who can bill directly to the payer? CPT came out with something specific to this, that if you can independently directly bill to the payer, then you are considered a qualified healthcare professional. Well, they actually put that back in for 2023, which was great. And so what was really tough is that a lot of the reports, yes, actually Stephanie just said something, how did you identify this? The actual, it's not funny, but it's kind of amusing. The actual documentation said this person RN. I mean, it wasn't even hidden. So I said, wait, why is an RN billing for a level 4? I mean, I'm going through all this, and the payer was just like, we don't even want to touch it. Can you just do it? Otherwise, we're going to send it to a RAC provider. Can you just look at it? Because we want to do it at the CERT level. We're not happy. So it was ridiculous. how much time, how much we've done. It took almost 2 months. I'm almost done with it. But not only are they going to have to refund, they're going to get fined. It's a mess. And so, and I'm usually one that can really adjust for the physician. I'm such a physician advocate, but not when you blatantly don't follow the rules. So, and when you're saying that an RN is an NP or a PA, or giving them, equal credentialing just because they've been with you forever, you're talk about a slippery slope. And now it's considered a fraudulent situation. So I'll kind of leave it at that, but it was awful.
And let's quickly make sure that we're all on the same page, because you hear these terms ancillary staff, but you also have another term, which is auxiliary staff in a medical practice. And when you're talking about auxiliary, it means that you're providing supplemental help, right? You're offering additional support. So the words ancillary and auxiliary both carry the meaning of lending help or support, but ancillary carries the connotation that the support is considered subordinate importance, while auxiliary does not carry that same connotation. So,
Sean, can you imagine if there was something that happened that a patient died, or if a patient had an adverse outcome? They were very lucky that we didn't really find any of that, but it was just, they were charging patients their copays, their deductibles. Patients are being charged to see an RN and not to see an actual licensed provider that they expected. It was awful.
That's just pure insanity. That's pure insanity. All right. So look, there is a, if you're on LinkedIn, there was a link that Sarah Campos posted for the Medicare Advantage risk adjustment data validation and the final rule. It's a fact sheet. So it is there. It's available for everybody to download. All right. So as always, I want to thank this incredible all-star panel: Paul Spencer, Stephanie Allard, Terry Fletcher, Scott Kraft, Christine Hall. Thank you all so much for being here. Tomorrow, I'll be back with another episode with Terry Fletcher on our hashtag Terry Tuesday, as I already talked about. But tomorrow afternoon, I hope y'all can tune in and hang out with us. Emmy Award winner, undercover millennial, globetrotter, just unbelievable all-around human being. Clint Pulver is going to be live on my podcast tomorrow at 1:00 Eastern. If you do not know who Clint Pulver is, you are going to be absolutely blown away with this individual. He was the former drummer for Tim McGraw and Carrie Underwood and several others, but he became the undercover millennial. And tomorrow we're going to be talking about the management masterclass in how healthcare executives are able to get more out of their people and more out of themselves. And we're going to tie that directly into the world of compliance. So I hope y'all can join us tomorrow. But again, for today, thank y'all for tuning in, logging on, and hanging out with us just for a little while. And until tomorrow, remember, be good to yourself, but more importantly, y'all be good to each other. Take care.